We've heard these numbers for a very long time. Yet we come back to the same conversation and we sit and we hear and then we go back and do our jobs like we've always done them. And so today we are inviting you to think differently about this information today and to see it a little differently and to hear it a little differently. And you've heard Dr. Liu talk about, we are going to talk about a regional response. That's going to require change and it's going to involve challenge. So we're going to engage you in a conversation about what's going on in the East Bay and what's going on in the West Bay. We're going to talk about how we can bring this together and have a Bay Area response. That requires you to start thinking differently. Quite frankly, we didn't even really want the numbers presented because we know them. Was there any new information that you got there other than the NIH funding differential? Was there anything new? So, with that in mind, we're going to talk now about what is happening in the East Bay. You're going to hear a little bit about the efforts to get to zero and the efforts to coordinate services. And what's really wonderful is, we're in March, Women's History Month, and the next 3 speakers we're going to have are all women. And that's very important in the leadership and the response to this epidemic, and to honor that as well as we are celebrating the history of this epidemic and the response. We're going to hear from 3 women. We're going to hear from Phoenix Smith, who is director of our HIV care programs in Alameda County. And the unique thing here is Phoenix and Sophy and Carolyn all have more than 25 years experience in working in the epidemic, right? So we got 75 years of history, involvement, and engagement in working in HIV. And so Phoenix comes at it from having been in Baltimore and Washington, D.C., and now in Oakland, and has a background in substance abuse and working with people of color, African immigrants, and blends all that when she comes to now her shop here. Sophy, we kind of consider Sophy our community doc, right? Medical director for HIV access. She's medical director for AIDS Education and Training Center. She's very involved in helping the providers kind of get it right. But she's also part of the team that's helped us get it right in terms of linkage and coordination of care and making sure our folks stay in care and are retained. And so we bring that to you this morning from our Alameda County perspective. And then we're going to hear from Carolyn, who is of Native Hawaiian and Apache heritage, and she's going to tell us a little bit about kind of where the Indigenous response is. And she has a long history of engagement of working in planning bodies and working in organizing and capacity building to help our communities get it right. So our next 3 speakers are going to come from, all of them have a history of working in community. All of them have a history in working with people on the ground. And now they're in positions to be able to help us shape our thinking about our next step, okay? So you're with us? Al gave us our sense of San Francisco. Overview of the numbers important, but now we know what's happening in San Francisco in terms of getting to zero. Now you're going to hear about what's happening in the East Bay getting to zero with our services and programs, and then another little spin on it in terms of Indigenous populations as well. We're being inclusive today. And with that, I want to invite Phoenix to come up, and then we're going to hear from Sophy, and then we're going to hear from Carolyn. And on the way out, I want you to know, I was in LA on Monday. I was very proud of the LA Times. Come on up, Phoenix. There was an article at the bottom of the LA Times, and it says, "Meet the mayor who dared to take on the president." I was very happy that the LA Times had the Oakland mayor on the front page. And then I went inside to look at the story. It was very interesting. Here's a picture of a group of people protesting in support of, right, this action. The picture is San Francisco. So how does that happen? That a story about Oakland becomes a story about San Francisco? Can't be. Thanks, Phoenix.
Wow, okay. Well, thank you very much for that wonderful introduction and helping us all kind of get pumped up for this. So I'm Phoenix. I'm the director of the Office of HIV Care. I just wanted to bring this quote from James Baldwin, because we are now being faced here in this country, I would think, around, we need to, not everything that is faced can be changed, but nothing can be changed until it is faced. So I think that's what we're dealing with right now. So I'm just here to give you an overview. Sophie's going to drill down into what we're doing in East Bay Getting to Zero, but I'm here to set the context and give you the big vision. And so we had the information around the BART stops and the life expectancy. In Alameda County Public Health, we've had a Place Matters initiative for many years, looking at how place and race impact health. And so as you can see here, West Oakland, which we have many people from San Francisco moving to, but people that have been living there for a long time, has a life expectancy compared to an African-American child compared to a white child has a pretty big difference in life expectancy. So this is important, and why am I focusing on a child? Because what we're seeing in East Bay is the rise in cases of HIV is among young people of color. So this slide here, when I first saw this slide, it just blew my mind. I turned 50 years old in January. I'm not saying that for you to clap for me. What I'm saying is, if you look at this slide, it says that the persistence of neighborhood poverty by census tract, right? So what we have here is that high poverty that has been persistent here in these areas for 5 decades. I'm 50, so that's 5 decades. Intergenerational, persistent poverty, one generation after another. This is very important. This means they have whatever our social systems and political systems and public health systems have been trying to address, we have not done the good job. Because we still, in this country, in this area that has tremendous wealth, we have neighborhoods that have decades and decades of poverty. And we know, those of us that have worked in this field and those of you that work in it now, as African Americans, we've always known that HIV is just one of many issues. It's not, and for many African Americans, it's not the biggest issue. So I want to challenge us here today. I know we're talking about HIV disparities, but we need to broaden our approach as we are going to be talking about a regional approach, but we need to understand that it's more than just about HIV. 5 decades of poverty in these neighborhoods is a shame. So what is the landscape of HIV? Historically, we've had reduced, flat, and stagnant funding. We have a larger percentage of African Americans, as Dr. Liu showed, in Alameda and Contra, Costa in San Francisco. We still have largest percentage of African Americans, late diagnosis, new diagnosis prevalence. We have a large, diverse county, but we have pockets of socially conservative cities. And so as we talk about migration, Oakland, yes, we have many clinics in Oakland, but many of them are now unstable. But we have people that may travel to other clinics that are outside of Oakland and Alameda County. And some people from Tri-City can possibly talk about what happens when you're traveling from Oakland to get to Transvision and Fremont. Do you get stopped at the BART once you get to Fremont? The profiling of African American trans women as they're trying to get to the wonderful Transvision clinic in Fremont. So we have to also understand this also, that we see ourselves as a very liberal area, but when we move outside of San Francisco City and we move outside of Oakland, people are going into socially conservative cities that don't necessarily support our communities and the efforts that we're trying to address. We have an unstable HIV service delivery network in Oakland. We have an unstable HIV. What do I mean by that? We are still very fortunate and blessed that we have community agencies that focus on specific populations. We have community agencies that have been around for many years, founded by and run by African Americans that are struggling just to stay open. In Oakland, we still have a Bay Area state of emergency for African Americans and HIV. In the 90s and early 2000s, that was very common around many cities as a way to address disparities. A policy way to address disparities is that a lot of urban areas created these state of emergency because it was a state of emergency in our community, right? And that was a political and policy strategy to get local and county governments to pay attention and put resources and funding. It's the same thing that happened with Minority AIDS Initiative funding. If you don't know the history of that, the Congressional Black Caucus lobbied. And why did they lobby? Because local Black activists in New York, in Oakland, in Baltimore, and Philadelphia pushed their local Congress people saying, it's a state of emergency in our cities. We need the federal government to do something. And so the Congressional Black Caucus formed Minority AIDS Initiative funding. This funding has supported many communities. But what we're having here in Alameda County is we have an unstable HIV service delivery network where agencies are struggling to stay open. They don't have access to many of the innovative interventions that happen in San Francisco. They don't have the level of funding. In Alameda County, we are the only source of funding for public HIV funding. That's the Public Health Department. The city of Oakland does not provide any dollars, right? They do not provide any dollars into our HIV epidemic. We don't have a large nonprofit network, or we don't have a San Francisco AIDS Foundation in Oakland. So the majority of funding comes from work that we're doing in the Alameda County Health Department, me and Nick and now Steve, working on increasing our funding in the Alameda Health Department because there are no funds coming from the city of Oakland, not since when Ron Dellums and Marsha Martin did the Get Screen Oakland, and that was how many years ago? A few years ago. So again, I just want you to understand, and so this continues to contribute to an unstable HIV service delivery network. You know, just yesterday, 2 days ago, because I work in the health department and we administer all the Ryan White funds, people call me all the time. Providers call me, clients call me, and we receive call that another one of our agencies lost some very important HUD funding, HOPWA funding, for a variety of reasons. We know that the political climate in Washington, especially around HUD, if you've been reading the news, things are shifting and things are changing. So this contributes to increased anxiety and potentially more people being lost to care with the unstable service delivery network. So the disparities I'm showing here, I'm not talking about HIV, right? This is from our Place Matters data. Again, and Sophy will point out when she comes in and give you more data around specific populations. But in Alameda County, African-American youth are nearly twice as likely to live in poverty. Twice as likely. We saw the map with the 5 decades of poverty in certain neighborhoods and certain zip codes. In 2009, the graduation rate for African-American males was 49%. Only 49% of black males, and it's probably not even better, it's probably no better now, were graduating from high school in Alameda County. We know that cofactors for HIV transmission and acquisition are poverty, are low education, or unemployment and underemployment. African American men are 2 to 5 times more likely to be hospitalized for hypertension, diabetes, and other illnesses. So yes, we may get to zero, but African Americans are still dying from strokes, from hypertension, and living with HIV, right? So getting to zero, is a wonderful goal, and it's great that we have a vision in this community, in this country, for getting to zero new HIV diagnosis. But in the African American community, and I would say to some extent the Latino community, HIV may not kill you, but diabetes will. So we really need to look at an intersectional approach to our work. And I say this jokingly to some of my young black gay male friends, right, that the way that we look at young gay men in the field is we look at them from a point of view of either their dick or their ass. And why do I say that? Because we need to have more holistic approaches to people's health, right? Sexual health is very important, but so is your spiritual health, your cardiovascular health, your mental health. Dr. Liu showed the data that with trans women, high rates of depression. We're seeing suicides, high increased suicides among young black males. So this data is not about HIV, but it's about the cofactors that lead people to becoming increasingly exposed to HIV. Again, in Alameda County Public Health Department, with our Place Matters initiative that is not just about HIV, we're starting to talk about a framework for health equity. And I hope that this conversation can lead us from just saying disparities, but to have a framework for health equity. How do we move the conversation? And when we talk later about a regional response, this was adapted from the Bay Area Regional Health Equity Initiative, BARHI, where they're looking at, as you can see here, upstream social factors, a social ecological model, and then the medical model. We still focus mostly on the medical model here in HIV, right? And when you saw the slide around the disparities in funding in Alameda County for prevention, which can help to address some of the upstream social factors, we're like dog pedaling. We're kind of drowning, right? Because we don't even have enough to be able to address the issues. So I really hope that we're able, and one of the things that we talk about in our East Bay Getting to Zero effort is really how can we have a more holistic view of our approach to getting to zero. We are just starting. We are not where San Francisco is. We are just starting with our efforts, but we're hoping that we can move to more of a framework for health equity with less of a primary focus on the medical model. How do we work across sectors to share information? I used to work at Tri-City before I came to the health department, and we experimented with a new idea, and they're going to talk about this later, but we were considering applying for a Trans Women of Color SPINS grant, and people were having the same old conversations. Oh, let's do more testing. And what I know about, especially a lot of trans women of color that I know, one of the biggest problems they have is because they get targeted and profiled and stopped by the police a lot, you get arrested, you end up having a record, which means you can't get a job, you can't go to school, which means it's difficult to do anything in life if you have a record. And so we decided to partner with a legal clinic to help expunge the records of trans women of color so that they could at least be able to start on solid footing to get an ID card, to be able to go to community college or whatever it is that they need. So this is one way that we were looking at how do we experiment with new ideas and new partnerships, and you'll hear more about that later. So now that's enough for me, and Sophie's going to come and give you more information. Thank you.
Good morning. Thank you, Phoenix. Thank you, Phoenix, for laying the foundation for our Getting to Zero initiative and also for a vision for health equity, because that's really what we're trying to get at, right? So I'm going to give you an overview, and sorry, Marsha, but I'm going to give you a little more data. So I'm going to just give you a few more East Bay details, and thank you, Al, for also laying that foundation. I'm just going to spin it in a little different flavor so you can see it slightly differently. I'm also going to describe the interventions that we've been trying and some of the outcomes that we're seeing related to those interventions, and then leave you with some interventions to think about as you go through the day and you generate a lot more ideas and discussion through the different plenaries and workshops today. Okay, so fresh, hot off the press, thanks to Nina Murgai and her team, is the Alameda County HIV Care Continuum for 2015. And you can see really here, what I want to show you is our biggest drop-off, as it is in most places across the US, is with linkage and retention. Our overall viral load suppression rate's a little better than the state average and the national average at 67%. But you can see here, geographic distribution really matches the map that Phoenix showed about poverty in Alameda County, right? It's really along this 880 corridor, the flatlands as we call them here. Just to orient you a little bit, we're up here in Berkeley. This is where I live. The hot spots are West Oakland, downtown Oakland, which you saw Kirsten Bibbins-Domingo's BART map. It's kind of like that. It looks like this, right? And then also another hot spot in central East Oakland. Contra Costa, thanks to Martin Lynch, this is their map, and you can see hot spots here, Richmond, right? Richmond, El Sobrante, San Pablo area. and then another spot here in Antioch and Pittsburgh. So some uneven geographic distributions in HIV prevalence as well. This is Contra Costa's HIV care continuum, and it's very similar to Alameda County's, except that it's a bit better. So our neighbors are doing a bit better around linkage and then retention and care, but again, the biggest drop-off is here, right? And then viral load suppression's a little bit better at 70% overall. So looking at disparities in a slightly different way, Al showed the bar graphs, and what I wanted to pull out were the ratios. So here are the ratios for African American health disparities in HIV diagnoses. So for Alameda County, 3.7 times the HIV prevalence rate compared to whites, right? And Contra Costa County, 4 times the new diagnosis rates compared to the average. So really striking disparities in new diagnoses and HIV prevalence overall. In addition, thanks to Megan Crowley and some of the folks, and a lot of the folks here from our HIV access clinics, we actually have a specific health disparities analysis done with our Ryan White Part C clinics here in Alameda County. That includes the clinic at Highland Hospital and the 4 federally qualified health centers, and that's about 1,300 patients living with HIV in Alameda County. And what we found was there is a group consistently, year after year, that is less likely to be retained in care and less likely to be virally suppressed. What is it? Demographic group. African Americans less likely to be virally suppressed. This was a different group, actually. Youth, that's right. So young people, especially our youngest people, but this actually went up to age 39. So it was like anybody under the age of 40 was less likely to be retained in care, less likely to be virally suppressed, about 2 times less likely. And you can see Megan's poster that's out in the poster session. She also used some open access tools that she's willing, she'd be happy to show you around that if you want to do that for your clinic as well. So this is the county data, which also mirrors that. This is from 2015. Our HIV access data was just from this past year, so it's pretty fresh. But it's the same thing. Year after year, it shows that young people under the age of 40 less likely to be virally suppressed. And then we also found a group, which you already named, which was less likely to be virally suppressed, but weirdly, for us, African Americans were 1.6 times more likely to be retained, so folks are coming in, but 1.7 times less likely to be virally suppressed. So there's something going on here that we really need to figure out. And so this, for those of you who are doing disparities research, we'd love to help. We'd love your help figuring out, why is there this disconnect? Is it stigma, beliefs around medications? Is it access to pharmacy services? Is it insurance coverage? What is this that's creating a disparity also between retention and viral load suppression? Maybe all of the above, yeah. And then also ideas. Important stuff, right? It was in us, right? The fire is in us. We just needed a little kick to get started. So now we're getting together. A newly formed testing group a testing working group is now convening. We've had an East Bay linkage and retention group. This is an old photo, and we just met yesterday, which I need to update. But this is an old photo where we were meeting at CalPEP, which is one of our CBOs and our partners in the East Bay linkage and retention group. We've been meeting for 4 years. We also have a PrEP network that was started last year with Jiba Korande and Sammy Lubega at the Alameda Health, and also co-hosted it at the Department of Public Health in Alameda County. So what have we done through the linkage retention group? I can tell you more of the interventions here, and I'll just use this as a case study. So in 2013, we got together and we were like, okay, what are the issues here? And basically, most people spent the first year kind of complaining about stuff. This is what happens when we get people together. All the dirty laundry gets aired out, right? So we're like, well, we can't even get through the phone line when we try to get a new patient into care, right? So the first thing we did was set up a contact list. Who are your single points of contact? What are your work cell numbers? So when we call, we actually reach a human being. And can we have agreements in place? You'll call us back, as soon as possible, right? So we also established the warm handoff protocol, which is an agreement between our community-based organizations and our clinics and any of our care sites that are part of this network to say, if we have a new diagnosis or somebody new re-engaging in care, we call somebody and you're gonna get back to us right away and you're gonna get us an appointment. So I'll share with you in a minute that we're now doing rapid linkage in ART. So it's improved a lot since 4 years ago. In addition, in 2014, the HIV Access Network clinics developed linkage and retention protocols. So basically, we're getting our ducks in a row. We're getting our systems in place because we didn't really have systems before. So kind of laying the foundation is like getting your systems in place, having protocols so no one gets left behind, right? So what are the results of that? Well, and then rapid ART. So just briefly, in 2017, 4 of our federally qualified health centers, Asian Health Services, La Clinica, Lifelong, and Tri-City, we all launched rapid linkage in ART projects. And I'll show you the results that were just analyzed this week from that. Okay, so looking at our linkage data, what are the outcomes that we can see in terms of linkage? So our baseline is just county. We didn't have HIV access linkage data at that point, but in 2013, linkage to care within 90 days, which is actually defined by labs, was 73%. That was the year our linkage and retention group formed. Now we have HIV access data going forward. So these are the federally qualified health centers. And 90-day linkage then increased a bit to 83%. 2015 increased to 94%. 2016, it kind of leveled, it went down a bit to 90%. 2017, just analyzed this week, 96%. Actually, from diagnosis to antiretroviral therapy was 96%. So yes, we can actually do this. This makes a difference. Putting our minds and our commitment to this really does make a difference. And so if we drill down, we actually got 92% within 30 days and 84% got same day ART. So thanks to all of our HIV access folks on the floor, on the ground on this. So yes, this makes a difference. We can turn these broken links into something more like this. When I talk to my patients about it, I did an informal survey of my own patients, what keeps you in care? And invariably, they tell me this. It's the personal touch. It's the fact that when I come in, you don't judge me as much as other people. You accept me for who I am. You let me talk about what's really bothering me, right? And that's people skills, right? We don't really learn this in nursing school or medical school. I mean, I think more now, right? But traditionally we haven't. I didn't. So, can we learn better cultural humility? Can we learn better trauma-informed care, motivational interviewing, strengths-based counseling? And this year with the AATC, we're trying to roll out some more of these people skills workshops. And this is something that Phoenix had mentioned too. Can we actually, we're not reaching about 30 to 40% of our population through traditional healthcare systems. So can we be more comprehensive and address poverty issues, housing issues, legal issues through comprehensive care services? Can we be more holistic, non-traditional, and have open access, right? Open access for people who work during the day and need to do that. Can we have street-level access for people who are homeless in encampments? We have this HEPAC and STOMP project doing some amazing work around that, and CalPEP doing street outreach around testing. Can we actually meet people in their homes when they can't get out because of chronic pain or for whatever reason? Or phone-based visits or app-based visits. So really thinking about non-traditional ways to reach people as you go through the day and think about the populations we want to reach. Thank you very much.
I just bringing up the slides, I just wanted to say something. In about 1989, with the help of, I don't know, for many of you might remember Ron Ryle. He was the founder of the National Native American AIDS Prevention Center. He was very successful in being able, along with some other Native colleagues that were researchers, to get some money from HRSA through a SPINS project. And from that came the Ahalaya Project, which was the first Native American case management program. I happened to be part of that cohort. I was one of the first Native Hawaiian case managers on the island of Maui, and we were able to provide traditional, what I just heard, you know, you guys call it non-traditional, but we called it traditional HIV care. We were the pioneers of holistic care in the HIV world, and I'm very proud of that. In the early days, we talked about the fear of a medical model. We saw it coming. Unfortunately for myself and the cohort, we did have a evaluation piece to our project, but there were so many things that we did that we were not able to capture to demonstrate our success. But our traditional methods worked and changed the lives of many people. And so anyway, I'm here to tell the story. Okay, I kind of like doing that TED Talk thing, but I'm going to try this instead. Okay. And then I've got to use this, right? All right, forward, okay. So, you know, when they asked me to give a title to my presentation, I had to think about it. And I thought, you know, I'm going to do Indigenous UpRising. Because this is the past, I mean, for a long time, for the past 500 years, it has been an Indigenous uprising, but past few years, we have seen more, I guess because of social media, more Indigenous uprising, especially over the issue of protecting the water. And so I chose that. So this photograph is representing our Mahu Wahine Hina Wong. Some of you may know who she is, with her student. She was the first Mahu Wahine that was a teacher of a Native Hawaiian language immersion school on the island of Oahu. And then next to that are some of our Two-Spirit women. I think that photo is probably from the Two-Spirit powwow in San Francisco. So as Indigenous people, our past, present, our future, are conjoined and interdependent. Our narratives and stories are important for you to understand us. So what I'm going to be today is a storyteller of my people. My name is Carolyn Kauali'i. I was raised by my maternal grandmother, Kaena Kauali'i, who was full-blooded Hawaiian. And everything that comes from me that is good came from her. And she was married to my grandfather, who was from New Mexico, of Mescalero Apache ancestry. And my journey through my life, little did I know that I would be called into the service of HIV. It has been a life-changing experience for me, one that I have a major passion for, one that when I try and escape, it always draws me back in. And for those of you that have been doing this work for a long time, you know what I'm talking about. It's just we cannot escape it. It was our calling. And so at this time, I'd like to dedicate the story that I'm going to share with you to all those of my relatives, of the people that I served, that during the early days of this epidemic that have passed on, and for those that are still thriving and living and enjoying their life, because there are those too. So I'm going to start with American Indians and Alaska Native, and then I'm going to go on to Native Hawaiians and Pacific Islanders. So this is the map of the United States, and I don't have to tell all of you that the original people of this land are the Native American people, the indigenous people of this North American continent. And there are 567 tribes in the United States. Now, not to say that we don't care of, being the community of color, that we don't care, but because of political relationships with the United States, it's really important to understand that the Native people of this land don't necessarily see themselves as a minority group, nor do they see themselves as a people of color, but they see themselves as the first people of this nation. And the reason for that are for many, many levels of reasons, but mostly because we have a special relationship with the federal government. So this government-to relationship is equal. So again, there is 567 tribal nations. Now I'm talking about tribal, federally recognized nations. There are many tribes that are not federally recognized that were written off of the federal recognition role. And then there is the United States government and state governments. Now, there is supposed to be equality with those three. So they are the American family of governments. In California, there's 110 federally recognized tribes. California has the most tribes than anywhere in the United States, and 50 non-recognized California Indian tribes. And again, when I say non-recognized tribes, I'm talking about those that were tribes that the federal government literally wrote off at some time in history. In 1956, there was the Indian Relocation Act, and this is where many Indians were encouraged to leave the reservation and go to urban cities and start a new life, and to become, it was part of, trying to kind of break down the whole reservation system. And so this is what California looks like when it comes to American Indian and Alaska Native population. So California has 723,225 people that identify as American Indian and Alaska Native. And if you look over here, you can see that Los Angeles has the highest Native population, and the Bay Area comes in second. And within, you see the rural and the urban area. So of this population, 88% live in urban settings and 12% in rural settings, but only 3% live on reservations. So that makes 1 out of 9 American Indians, Alaska Natives live in California cities, 1 of 9 in the nation. And so what you see here is the what's considered the urban areas of California. And the California Consortium for Urban Indian Health provides services, and they're based out of here in San Francisco, but they help to service these locations that have Native health centers. And one of them is the Native American Health Center in San Francisco and in Oakland. But only 1% of Indian Health Service fundings go to urban Indian health. Now I'm going to give you a little history on Native Hawaiians and other Pacific Islanders. So when we think of Native Hawaiians and Pacific Islanders, we think of the anthropologists, titles for us is Polynesians, Micronesians, and Melanesians. And some of our names are Kanaka-Maole, Native Hawaiian, Samoan, Chamorro, Sampanese, Chuknese, Marshallese, Nappies, Palauan, Fijian, Tahitian, Tongan, and Maori. And I just wanted to put up here, this is the Native Hawaiian and Pacific Islander LGBTQI community. And so you can see that there's also it's a very big part of who we are as people. We honored our Mahu, Aikane, Fa'afafine community members. And so within the Pacific Island community, when we look at our Mahu and our Fa'afafine community members, we don't see them as a gender, we don't see them as an orientation, but simply an expression of a third person. So I want to talk a little bit. California has the largest Native Hawaiian Pacific Island population outside of the state of Hawaii. And this is because there's always been a migration of Pacific Islanders to the United States for a variety of reasons. But one thing I wanted to point out is when you think of Indigenous people, you have to think about a worldview and the way they view their world. And so if you look at here, you see that all these Pacific Islands is what in the Pacific Ocean. When we think of the Pacific Ocean, we think of a big mass of ocean and water, but to us, it's a continent. We live on the largest continent on the planet. So we have a very deep relationship with the ocean because of that. So when we talk about the history to the Bay Area, there are ancient stories from California Indians talking about Hawaiians coming to this continent way before the 1800s, and the stories of the Rainbow Bridge. So there's oral history regarding that. And then early migrations, Kamehameha II sent one of his chiefs here to get vaqueros to bring back to Hawaii cowboys from California that were of Indian and Mexican ancestry, because we had cattle running wild on the big island of Hawaii, and they were eating up everything. And so now we have, people don't know this, but we had cowboys in Hawaii before Texas did. And then there's John Sutter that came, and he brought 5 Hawaiians with him, and they settled the Sacramento area. And many of the native people there are of Hawaiian and like Maidu ancestry. In more contemporary times, we have the Matson Company that brought a lot of people here for work. The military, the U.S. military, many people in the Pacific joined the military. They came here for jobs, for education. And then one of the things, too, is the Compact of Free Association. So after World War II, especially in the area of Micronesia, because they were really devastated by the war, and the UN was established, the Compact of Free Association gave the responsibility to the United States government to be trustees of these people and to help them in rehabilitation after the war. So many Micronesians came to the United States and are still coming because of that Compact of Free Association. But I was talking to my colleague, Henry, who works out in the Pacific with Office of Minority Health Resource Center, and he was telling me that they have stopped, and Henry can talk to this more, he'll be on the panel, how the Micronesians and people from that part of the Pacific have less access now to health care here in the United States. A lot of what came with the Compact of Free Association has been now stopped. And then one of the newest things that are happening in the Pacific is global warming and the rising of the sea level. So what's happening to many people in the Pacific, we live on a big continent here, but when you live in the middle of the ocean and you live on a small island, it's a different kind of lifestyle. It's a different way of looking at your environment. And when the seawater level rises, you lose land masses. So many Pacific Islanders are now leaving their island home because of global warming. The thing that's interesting about that is their impact on the emissions is very low. So they're not the ones that's causing this to happen to their homelands, but they're the victims of it. And then the high cost of living and lack of employment on these islands. So I just want to kind of go over a little bit about the relationship that the United States government has with these different island groups. So yes, they're immigrating to the United States, but they do have a relationship that the United States has somewhat of an obligation to oversee and care for certain people through the Compact of Free Association and other political relationship. So I'm going to begin with American Samoa. So the people from American Samoa are U.S. citizens. They're considered U.S. nationals. And then the Hawaiian Islands, as you all know, is the 50th state. And they have a special relationship relationship since the time of the Kingdom of Hawaii through many treaties with the United States. And they have over 200 specific laws passed by Congress regarding Native Hawaiian legislation. American Indians, Alaska Native, and Native Hawaiians are the only people that have access to the federal government through consultation. And then you have, in the blue area, in the Micronesia area, you have Palau, the Republic of the Marshall Islands, and the Federated States of Micronesia that fall under the Compact of Free Association. So some of these groups may be immigrants to the United States, but they have special relationships with the United States government. So this is just to give you an idea of the population size in California. So you can see that California has the most populations of Native Hawaiians and Pacific Islanders. And you can see that, which is very surprising, people from Fiji are the fastest growing populations of Pacific Islanders here in California. And the other thing that I find that's really interesting is that it's projected by the Census Bureau that by 2050, there'll be 2.6 million Pacific Islanders and Native Hawaiians living in the United States, in the continental US. Give you an idea of the breakdown of population within the local counties. And once again, the population size of the different Native Hawaiian and Pacific Island communities within the Tri-County area. Okay, so now I want to kind of cover just a little bit about HIV and American Indians, Alaska Native, and Native Hawaiians and Pacific Islanders. So this is from CDC, and so nationally, American Indians and Alaska Natives are ranked number 5 when it comes to HIV diagnosis. And one of the things that I want to bring up is the idea of IDU, and considering the population size of American Indians, Alaska Natives, the injection drug use rates are quite high, and there is a problem within the reservations when it comes to opiate use, so that is something that has to be addressed, and it's a very difficult thing to address because of stigma around that and lack of services. It's usually the outside harm reduction groups that are like on the outskirts of the reservation trying to provide services, but very little, I think, interaction with local health departments. So this is some of the things that needs to happen within the IDU use. So these are just some quick facts. Because of the population size, there's always some unobvious reasons that could cause, what the reasons for HIV infection within the population size. And then also, when you look at the estimated people living with HIV, they figure there's about 18% that were undiagnosed compared to the general population, which is 13%. And there's 78% linked to medical care within a month, 53 retained in care in less than a year, and 52 were viral suppressed. Over the last decade, annual diagnosis increased 63% among gay and bisexual men in the Native American population, which I think is pretty important to really think about. So the challenges that we have in Indian country is just access to good prevention programs and care and treatment, and just the high rates of STIs, and again, the stigma. And also the lack of resources within the Indian country to address these issues. Then when we look at Native Hawaiians and Pacific Islanders, they're considered the third highest rates of HIV diagnosis in the United States. One of the things is there's limited research around the health and HIV infection and the small population number. The other thing that we have problems with is the category of API that really does not serve us. And I want to kind of share you a little story about that. Just recently, I went to have a mammogram done. And when I checked in for my intake, I didn't have, they asked me, okay, like I was looking at it, they did not have Native Hawaiian and Pacific Islander. And my only choice would be to pick other. And I refused to do that. And then when I went in for my mammogram, the technician that was helping me, she had to fill out a form. And she put me down as other. And that really bothered me. And so the second point is that, there is a lot of misclassification and underestimation of HIV infection because of that. And so that is a problem when it comes to data collection for this population. So this one here just shows you the rates in California, and I don't know if you can see, that's pretty tiny. But even though Native Hawaiians are third for newly diagnosed, they're actually doing pretty good when you compare them to African Americans and the rates that are there. So we're just third, but we're doing pretty good when it comes to rates. But again, it's not having, not knowing if we're really collecting and gathering our data correctly because of misclassification. And that's the same thing for people living with HIV. American Indians and Pacific Islanders and Native Hawaiians look like we're doing pretty okay. But again, we have to think about the way data is collected for our population. And then what I want to show you here is that this is the care continuum among persons newly diagnosed. And what you'll see here is, so when you look at the achieve viral suppression, American Indians aren't doing too good on that one. They could, we could do better with that. But this next slide, what I want to show you is under Native Hawaiian and Pacific Islander, you see that, and this is in Alameda and Contra, Costa County, and you see that we're really up high. So what this tells me is that, and this is for the percentage of newly diagnosed who were diagnosed with stage 3 HIV. So what's happening with Native Hawaiians and Pacific Islanders is when they get tested, for most part, what we're finding is they're coming in with an AIDS diagnosis. So what this is telling us is that there's a possibility that we're missing a whole lot of people that are possibly HIV infected. So one of the things that happened when Obama was in office and he signed the Patient Protection and Affordable Care Act is that the Indian Health Care Improvement Act was permanently reauthorized within that act. And I don't know if you guys realize it, but every 4 years, that had to go to Congress for refunding. And what happened is it never got refunded right away. And so Indian Health Service would wait 3-4 years before Congress would finally, reauthorize the act. So now it's permanently reauthorized through the Obamacare. And the Native Hawaiian Healthcare Improvement Reauthorization Act was also reauthorized at that time under the IHS Indian Healthcare Act, and it was reauthorized for 10 years during that time. And then through that, the Indian Health Service established a position, the Director of HIV/AIDS Prevention and Treatment, who happens to be a really good friend of mine, but he hardly has any funding. I just want to bring that up. So the problem with American Indians and Alaska Natives and Native Hawaiians and Pacific Islanders is that we no longer have any direct funding coming to our population. Oops, I hit the wrong thing. And, sorry. So what has happened to our community is that we do not have the voice anymore, and we're trying to reestablish that.
through getting involved more on a national level. And we've had several committees and consortiums and to come together and try and regain our voice on a national level. And anyway, thank you very much.